Welcome. In this session we will be discussing about neoplasia masquerades, which are actually non-neoplastic entities which can mimic intraocular neoplastic conditions. There are many conditions which fit this description, a few of which we have discussed in previous sessions and many which we will be taking up in more detail in their respective sections. A clinically relevant classification of these entities are those simulating anterior segment tumors, those simulating choroidal tumors, and those simulating retinoblastoma. So starting with non-neoplastic lesions which may simulate anterior segment neoplasms, we have cysts of iris and ciliary body which are of two types, the neuro-epithelial cysts and the epithelial inclusion cysts. The neuro-epithelial cysts arise from pigment epithelium of the iris or the non-pigmented epithelium of the ciliary body. When they arise from the pigment epithelium of the iris, they are dark brown in color, and when they arise from non-pigmented epithelium of the ciliary body, they are usually translucent in appearance. They are composed of a thin wall containing a clear serous fluid. They can be single or multiple, and they do not disturb the iris architecture. Ultrasound biomicroscopy, as shown here in this photograph, demonstrates the cystic nature of these lesions, differentiating it from other tumors which appear more solid. Neuroepithelial cysts of the iris can arise either from the pupillary zone, the mid-zone, or the peripheral zone of pigment epithelium of the iris. When they arise from the pupillary zone, they are visible on slit lamp examination before pupillary dilatation, and they neither distort pupillary margin nor do they interfere with pupillary dilatation. When they arise from the mid-zone of the iris, they appear as anterior bulging of the iris before pupillary dilatation, and following pupillary dilatation, they appear as a dark ridge-shaped mass in front of the lens. When they arise from the peripheral zone of the iris, they appear as anterior bulging of the iris both before and after pupillary dilatation. The other type of iris cyst is the epithelial inclusion cyst, which can occur either as a congenital malformation or following globe perforation, either surgical or traumatic, and they appear as off-white to bluish grey in color with thick walls containing turbid fluid with suspended particles, and this can be confirmed by ultrasound biomicroscopy. Unlike neuroepithelial cysts, they distort the iris architecture as well as the pupillary margin as seen here in this photograph. The thick wall of an epithelial inclusion cyst of the iris is made of conjunctival epithelium invading the globe, and the intracavitary suspended particles are desquamated conjunctival epithelial cells. Anterior segment staphyloma is a scleral thinning along with anterior bulging and increased exposure of the underlying uveal tissue. It can be mistaken for a ciliary body or anterior choroidal melanoma, but with transillumination test will get a brighter reflex in the region of the staphyloma instead of blockage, which we expect in case of a pigmented tumor such as melanoma. Ultrasound biomicroscopy shows scleral thinning without an underlying mass lesion. Inflammatory granuloma of the iris and or ciliary body can also simulate an anterior segment tumor as seen here in this photograph, and these granulomas can be either infective or non-infective. They will be associated with other features of uveitis such as keratic precipitates, anterior chamber reaction, synechiae, and hypopyon. An iris foreign body can mimic an anterior segment tumor, but these patients usually give a history of trauma, although an entry wound may not be found upon examination. But ultrasound biomicroscopy usually shows the hyperechogenic foreign body within the mass. An advanced cataract with posterior bulging may resemble a ciliary body mass during ultrasound B-scan examination, particularly when peripheral retina is being imaged, when the waves pass through the posterior aspect of the bulging lens, giving an impression of a ciliary body mass. But this impression of a mass will occur in all four quadrants, and there will be no blockage on transillumination. In the iris nevus syndrome variant of iridocorneal endothelial syndrome, which we will be discussing in more detail in the glaucoma section, there can be multiple tiny projections on the iris of the same color as the iris as seen here in this photograph. Coming to non-neoplastic lesions simulating choroidal tumors, we have congenital hypertrophy of retinal pigment epithelium, also known as CHRP. These are congenital non-neoplastic lesions which appear as flat, sharply demarcated and darkly pigmented lesions which can be 1 to 10 mm in diameter. In young individuals, they appear homogeneously black, but in older individuals, these lesions develop patches of depigmentation as seen here in these photographs, and these patches of depigmentation are known as lacunae. Chirpy can be single or multiple, and they can also be grouped when they are known as beard tracts as seen in this photograph. They need to be monitored periodically because rarely they may give rise to adenocarcinoma of retinal pigment epithelium. Chirpy can be associated with Gardner syndrome, in which there are multiple polyps in the colon with high risk of malignant change to colonic adenocarcinoma. But the chirpy in Gardner syndrome is atypical in appearance as shown here in this photograph. In Gardner syndrome, the atypical chirpies are bilateral and scattered, are oval in shape, and have a halo and a fishtail-like depigmentation directed towards the optic nerve. Acquired hyperplasia of pigmented epithelium of the retina or the ciliary body occurs in response to blunt trauma or intraocular inflammation and appears as a darkly pigmented lesion with irregular margins and surrounding chorioretinal atrophy. On ultrasound, we will find moderate hyperechogenicity, and these lesions do not show further increase in size. Subretinal hematomas may simulate choroidal tumors, and they appear as dome-shaped dark red to dark brown mass. Unlike choroidal melanomas, hematomas on ultrasound shows irregular high internal reflectivity with lack of spontaneous vascular pulsations. Subretinal hematomas can occur in the posterior pole due to neovascular age-related macular degeneration, polypoidal choroidal vasculopathy, and macroaneurysms. Subretinal hematomas in the retinal periphery can occur due to PEHCR. In neovascular age-related macular degeneration, the fibrosis itself can have pigmentation resembling a choroidal pigmented tumor. PEHCR occurs in elderly individuals and is considered to be a peripheral form of AMD, in which suprachoroidal and subretinal hemorrhages develop peripherally and spontaneously resembling hemorrhagic choroidal detachment. However, retinal detachment is uncommon. The other eye shows signs of similar peripheral chorioretinal changes. PEHCR involutes with time and requires only observation. In addition to a localized subretinal hematoma, a localized suprachoroidal hemorrhage can also resemble a choroidal tumor, and the suprachoroidal hemorrhage occurs between the choroid and the sclera and appears as a brown mass of uniform color, often with surface choroidal folds, as seen here in this photograph, in which this patient has bilateral suprachoroidal hemorrhage. A suprachoroidal hemorrhage usually resolves within 6 to 8 weeks. Varix of a vortex vein ampulla can also resemble a choroidal tumor, and varix of a vortex vein ampulla is a dilatation of a vortex vein ampulla which occurs in certain directions of gaze. It appears as a dark red swelling just posterior to the equator in one of the oblique quadrants, usually the supranasal or the inferonasal quadrant. The swelling flattens immediately when the patient changes direction of gaze, and a varix of a vortex vein may also be deflated by gently compressing the globe during ophthalmoscopy. An orbital tumor indenting the globe can also mimic a choroidal tumor, but in this case the location of the mass with respect to optic disc and fovea will change with change in direction of gaze. An ultrasonography or orbital imaging will confirm that the mass is extraocular. Sclerochoroidal calcification, as seen here in this photograph, can also mimic an amelanotic choroidal mass, and this is a degenerative change in the posterior choroid and sclera. It usually occurs in elderly individuals but can also occur in younger individuals with disorders in calcium metabolism, particularly in patients with hyperparathyroidism. It appears as an ill-defined elevated yellowish-white area which usually occur just peripheral to the temporal arcades. On ultrasonography and CT scan, these lesions give very high signals. Massive gliosis of retina is a condition which occurs due to glial cell proliferation in response to retinal inflammation or injury. It appears off-white in color and irregular in contour. Other conditions which may simulate choroidal mass lesions and which we will be discussing in more detail in their respective sections include posterior scleritis, bilateral diffuse uveal melanocytic proliferation, subretinal abscess, atypical RPE detachments, bullous central serous retinopathy, uveal effusion syndrome, Best disease, and endogenous endophthalmitis. And the choroidal tumor mimics which we have discussed previously include chorioretinal granuloma, VKH syndrome, and birdshot chorioretinitis. Now, lesions which can simulate an early intraretinal retinoblastoma in a young child include myelinated nerve fibers, chorioretinal coloboma, toxocara granuloma, toxoplasma retinitis, and focal retinal gliosis. Non-neoplastic conditions which may simulate an endophytic retinoblastoma in a young child are those conditions having dense vitritis such as pars planitis and endogenous endophthalmitis, which can be due to toxocara, toxoplasma, bacteria, and fungi. Non-neoplastic conditions which can mimic exophytic retinoblastoma in a young child are those conditions which can also present with extensive retinal detachment like an exophytic retinoblastoma, and these include advanced Coats disease with bullous retinal detachment, persistent fetal vitreous also known as persistent hyperplastic primary vitreous, congenital retinal dysplasia also called Norris disease if bilateral, and peripheral retinopathies such as retinopathy of prematurity, familial exudative vitreoretinopathy, and retinopathy of incontinentia pigmenti. To summarize, non-neoplastic disorders can mimic intraocular neoplastic entities, neuro-epithelial cysts arising from pigmented epithelium of the iris does not distort iris architecture or the pupillary margin, unlike epithelial inclusion cysts which arise from conjunctival epithelium. However, both have a cystic appearance on ultrasound biomicroscopy, unlike tumors which have a more solid appearance on UBM. On ultrasonography, advanced cataracts can give an impression of a ciliary body mass, but this will be present in all four quadrants, unlike with a true ciliary body mass which will show up in only one quadrant. Atypical chirpes or congenital hypertrophy of retinal pigment epithelium are associated with Gardner syndrome, an entity in which there is an increased risk of colonic adenocarcinoma. Localized subretinal and suprachoroidal hematomas may resemble choroidal pigmented tumors. Varix of a vortex vein appears as a reddish swelling of the vortex vein ampulla occurring in only a certain direction of gaze, and flattening when gaze is shifted to another direction. Sclerochoroidal calcification can mimic an amelanotic choroidal tumor and can occur in patients with hyperparathyroidism. Thank you for listening.